All right, we're going to get started here in about 2 minutes.
The mad scramble to the 0 hour. Welcome everyone, top of the hour. News brought to you by QLI. That would entail our banter.
Sounds good. Okay.
Laura, you can still hear us?
Yes.
All right, we got about 1 more minute. Still got some folks rolling in. Those of you just joining, we're a little quieter today because we've had some microphone issues. So it always creeps up on us. All right, ready to get started?
Let's do it.
Connor, welcome.
Thank you.
Those of you joining us, welcome to our November webinar. We're going to be talking about blood flow restriction therapy. Honestly, I know very little about this, so Connor, I'm excited to have you today.
Excited to be here. Thank you, Steve.
Before we jump in, you all know, go ahead and advance the slide for me, Connor.
Okay.
Get these first two out of the way. Just a reminder, this webinar is put on by QLI. We are a post-acute rehab facility based in Omaha, Nebraska. Those of you who are familiar and regular attendees, welcome back. If you're new to QLI, we specialize in brain injury, spinal cord injury, chronic pain, limb loss, and stroke. So pretty much anything catastrophic and anything complex neurological, that's what we do. We sit on about 60 acres here in Omaha. About half of it is developed. You can see a little picture of our campus. Our bread and butter is our post-acute program, but we also have an outpatient tele-rehab program. As far as today, we know that you're here to get some CEUs as well as to take home a few nuggets from Connor. But to get the CEUs, we just ask that you stay for the entirety of the presentation or as much of it as you can up until the end. There will be one poll question. There will be a slide that denotes when we launch that poll question. Please answer that. If you have an issue, let Don or I know. We'll get you taken care of. And then the last thing to get your CEUs, once you leave the webinar, you'll get prompted to fill out a JOT form. Once you hit submit, you will automatically get sent the CEU certificate as well as the slides for this presentation. So everything Connor is going to be talking about today, you'll have that in slide form. Just a reminder, CEUs are for CCMC only. So if you're outside of that, we apologize. Hopefully you still find this valuable along the way. So with that, Connor, I'll let you kick us off.
Okay. Well, thank you, Steve. Really excited to be here this morning with you guys to share what we've been doing with blood flow restriction here at QLI. We've been using this for about 1 to 2 years and seeing some really amazing results. So really just want to get the word out and just tell you guys what we've been doing and hopefully teach you something along the way. So before we get started, I just want to give you some learning objectives for today. By the end of this course, I want you to be able to describe the physiological mechanism of blood flow restriction therapy and how it's been proven and is being proven to promote muscle strength gains at relatively low intensities. Also, I want you to be able to identify the benefits and limitations of blood flow restrictions. We're still learning a lot about how this is helping our people get stronger. So a lot of research needs to be done, and I want to help identify those gaps as well. Another thing that we do really well is be safe. So we want to be recognizing the contraindications, precautions, and the way we monitor our patients during a blood flow restriction session. Also, we're trying to apply these evidence-based principles to integrate BFR into neurological rehab, including protocol design and patient selection. One gap in the research right now is there's no protocol for people post-stroke, SCI, TBI, and so that's one of the things we want to do is just get the word out there, get some case studies done so that we can get a larger research base going. And finally, evaluate current research findings and future directions for BFR in our population. So real quick, I'll give you a general overview of blood flow restriction. It's been used for a long time in the orthopedic and athletic field, but more recently we've been trying to integrate it into our neuro setting. Initially, a guy in Japan figured out that he was able to occlude his leg after an injury, and he had no atrophy following that. So he did more and more research. This is starting in the 60s, and over time, it got international recognition as soon as 2014. So more recently, we've been integrating this into our therapeutic scene. Essentially, what we're doing is using a specialized blood pressure cuff to partially occlude blood flow in one of the four limbs. This will make exercise feel more difficult, which will create a cascade of events to then build muscle strength. So why not use it for people that have lost muscle strength? So people after injury. So I've been focusing on using this with people with spinal cord injury, especially, and we've started to use it a lot with our people post-stroke as well. And before I get too far into the weeds, just know that there'll be plenty of time for questions or discussion during this. So if anything pops up during this talk, we can troubleshoot that as
Yeah,
well.
use the Q&A as a reminder. So we'll be monitoring that throughout. So yeah, thanks for the reminder, Connor. Use the Q&A if you have questions. But yeah, there'll be opportunities during and after. So thanks for the reminder.
Yep. Okay, so let's get into the physiology a little bit. What we use is a specialized blood pressure cuff. We use the Smart Tools device. It is a Bluetooth capable blood pressure cuff that connects to our phone. And what we do is we find the occlusion pressure of the arm, let's say, and that'll be a little more than your systolic blood pressure. So that top number. And then from there, we can partially occlude it at any percentage range. I've been using 50% for the upper extremity and 60 for the lower. So after occluding the limb, you'll have a partially occluded blood vessels in the arm, let's say, and what that's going to do is create an hypoxic environment. So we're lacking oxygen in the arm. And what that does is it makes our muscles work harder in order to perform the movement, simulating lifting heavy weight. So this is perfect for our people who have difficulty moving because it's hard to get them to max out with weights, let's say. So what we do is we make it harder by applying the blood pressure cuff, causing an hypoxic environment in order to make the muscle work harder. What this also does is our body is great at adapting, so we'll increase our muscle fiber recruitment, which then stimulates muscle growth. Among that, there's also a metabolic cascade that initiates a biochemical reaction in the muscle cell, especially after we release the blood pressure cuff. Just imagine an influx of blood coming in to just help heal what just happened during that workout. So just to review, I have 5 points here. We have a metabolite accumulation. So what's going to happen is once we deoxygenate the limb, there's going to be all these good metabolites building up in the cell that are not able to get out because the limb is occluded. What this does is it increases protein synthesis and it decreases proteolysis, which is the breakdown of muscle. So it's a win-win in that regard. And I also already talked about the hypoxic environment, but essentially what that does is it increases the activation of type 2 muscle fibers, which is our big, strong muscles or type fibers, versus type 1 would be more of an endurance type muscle fiber. Okay, and then 3, there's going to be blood volume and cell swelling. So I'm not an exercise physiologist, but essentially that increases growth hormone that gets sent to the muscle, and then also activation of mTOR, which is huge in muscle repair and growth. All right, where are we? We got vascular resistance. So anytime there is vascular resistance in the limb, that's going to increase the sympathetic neural response. So you think of our people with spinal cord injury, especially above T6, they're going to have deficits in their sympathetic or fight or flight response. By occluding and creating vascular resistance, that's going to tell our brain to activate that pathway, which could have multitude of benefits for these people, especially more complete injuries in the C spine, especially. And last but not least, the post tourniquet blood flow surge. So that sounds intense, but essentially it's hyperenemia following the occlusion. So it's a rush of blood flow with all of these good nutrients and all these good metabolites to then restore what has just happened to the limb, which is simulating a maximum lift. So it's a way to create change in muscle growth without overloading the limb with heavy weights. Hope that all kind of makes
A
sense.
couple, or at least one thing. So I see in the photo the blood or the BFR cuff.
Mm-hmm.
You mentioned the one that we're using. Are there multiple
Yeah,
cuffs out there? Maybe you're going to hit this later. I didn't see it in your presentation, but
yeah.
are there multiple cuffs? Like, what's the process for that?
There's multiple cuffs. We decided to go with this particular brand because it seemed relatively easy to use from a clinician standpoint, but also very accurate. And it gave us like very objective data so that if and when we do perform studies on this, we have the numbers on exactly how many millimeters of mercury we're occluding. But there's also Owen's recovery science. There's a lot of like bodybuilders use this technology, so there's a little some use a little more rogue strategies to occlude blood flow, but this seemed to be the most accurate and relatively affordable cuff that we use today. So,
Well, and then plus the research, because we are doing some research on it. So
yep,
that probably, like you said, drove the decision too.
exactly.
Okay.
And the feedback's great. I mean, there's so many different modes, so I'll get into this a little bit. I'm trying to formulate protocols for this. So I'm sticking to a certain one right now, but there is a way to utilize a blood pressure cuff for more endurance type activities. So we could start to implement this with walking. Say you have one impaired limb and one limb that's not impaired, you would put the blood pressure cuff on the non-impaired limb to make it almost the same as the impaired limb. And then, you could figure out different ways to rehab, but just some ideas throwing out there. There's different protocols that you can use with the smart cuff. Okay. So one of the reasons we really started thinking this would be a good idea was we were having some barriers with traditional strength training with people that have neurological conditions. I mean, think about it. They have just had sometimes a traumatic injury that's left them in the hospital for a couple months, and then they come to us. So they're very weakened, um, sometimes discouraged, a lot of times, and just looking for something to help them build their strength fast. With traditional strength training, it's essentially in order to build strength, you have to lift at 80% of your one rep max. Think about lifting at 80% of your one rep max for someone who's had a spinal cord injury at C6 and they don't have triceps to push a weight over their head. Well, let's find a way to make that as hard as lifting 80% of your one rep max, which would be the blood flow restriction cuff. And then they can do a simple movement that feels really hard. So that's one of, well, that's the barrier is lifting heavy weights. So that's why it's an advantage to use the blood flow restriction cuff. There's also safety concerns with high intensity exercise, especially in population that has a compromised nervous system. So by using the blood flow restriction cuff, we can minimize the intensity because there's safe movements. There's no heavy weights being thrown around. So there's a lessened risk of like joint damage or muscle tear or compensations that lead to a different injury in, say, the joint space. So I really love that side of it is it the patient will feel like they just got the craziest workout, but all they did was move their arm 20 times. And so it's super safe to do, but super effective. And they really feel like they get a lot of bang for their buck. And then finally, for high intensity interval training, you need cardiovascular endurance. Excuse me. And if you have been hospitalized for a few months, our cardiovascular tolerance is reduced. So by using the blood flow restriction cuff, we can simulate that high intensity cardiovascular response without getting their heart rate up by doing some crazy exercise on the ski erg or the arm bike or even the new step. So those are some of the barriers. I got into some of the advantages of blood flow restriction. Essentially, we can achieve strength and hypertrophy goals with light weights. So instead of using 70 to 85% of their one rep max to work out, we're using 20 to 30%. And that, like I said, could be just moving someone's arm or it could be a light resistance band and it's easily trackable. So I can change week to week how much resistance we're adding or maybe how many reps we're doing. It minimizes the joint stress and energy demand and also enhances neuroplasticity and functional recovery. I'll get to that in a few slides. The other thing I've noticed about BFR is it really improves the patient engagement and tolerance. I mean, especially for people who were working out a lot before injury, they feel like the type of exercises that we're doing in the rehab setting aren't as intense as they used to do. And so after doing blood flow restriction therapy, they're like, man, I really feel that muscle pump, or oh, this is awesome. I can't barely move my arm, and then the next day I'm actually sore. And that's what we want to get, and that's what we want to achieve in order for our body to help heal and build muscle strength. All right. Any questions about the rationale for using
We
this?
have a couple questions. One question is, are you able to perform this with a patient with hypertension or uncontrolled or elevated blood pressures?
That's a yellow flag. So we'd want to monitor. Um, we haven't been using it for people with hypertension at the moment, just as more research I think needs to be done with that. Um, but generally speaking, we've been using it for people that have 130 systolic and below. But yeah, you'll see in my contraindication slide later a whole list of red and yellow flags. And then what was the other one? Medications.
Maybe I'm a little slow on this one, but MTOR is the question. Um, can you expand on MTOR? So Tracy, I think you had popped that in there. You might need to give us a little bit more detail unless you know what that means, Connor.
It's a neurotransmitter. Yeah, it's getting into the weeds a little bit, but essentially it's a um I I'm pretty sure it's a neurotransmitter that helps build muscle.
Hmm. All right. There's another question on contraindications, but let's leave that because I know you have that coming.
Okay.
So let's keep moving.
All right. So let's talk about or let's reiterate some of the benefits of BFR and neuro rehab. Let's start with muscle hypertrophy and strength. I've been focusing more on strength just because that translates functionally. Our end goal is to build strength, not necessarily muscle size, but there's a lot of research in BFR in terms of hypertrophy and building actual muscle cell size. But I think that's more important for maybe the orthopedic and athletic population versus for our people, it's more about strength gains that can translate into functional gains, which translates ultimately into participation gains. Like we want to get our people back out into the community, back out doing what they love. Um, and so that's my main goal. Yes, it's a tool to use to get you stronger, but what's the end goal? It's to get them doing activities that they love. So by making gains with this 20 to 30% of their one rep max, we found a safe way um, to build strength without uh, a safety risk of heavy lifting. Then let's get into the functional recovery and neuroplasticity. So BFR enhances neural drive, which then improves motor control, which then improves functional mobility. And the main name of the game is neuroplasticity. We want to introduce novel tasks to create that neuroplasticity and a pathway for people to ultimately recruit more muscle fibers. Cardiovascular and metabolic adaptations. So blood flow restriction induces a sympathetic response without high intensity exercise, so it's safer for people with limited endurance, which is all of our people. I mean, we get our patients are anywhere from 2 to 6 months post injury, and so that initial acute hospital stay is going to limit their cardiovascular system. So we want to do a way we want to train them in a way that is safe and also very effective. All right, secondary complication prevention. So one of the thoughts that I didn't have that I started finding in some of the research is BFR may be a way to reduce secondary complications such as pressure injuries, osteoporosis, metabolic syndrome, all these things that are huge in our world. Think about someone who is losing muscle mass, they're going to have a higher risk to develop wounds, and also a higher risk to develop metabolic conditions such as diabetes. So if we can build stronger muscles, we can reduce those secondary complications. And finally, psychological engagement. Like I said earlier, I've noticed a change in just the intensity of exercise, and so people come here to get better. And when they see they're being challenged in a way that's really promoting these strength gains, they're excited and encouraged to come to the gym, and they're excited and encouraged to see how hard they can push themselves to ultimately reach their goal, whatever that may be. All right. A little bit of a busy slide, but essentially I wanted to show you 4 different studies that I looked at that showed different results in terms of the safety using BFR in the neurological population. The first top left is a systematic review looking at the safety and efficacy of blood flow restriction exercise. And to sum it up, essentially they found that it is safe and effective for people with neurological disorders. I think the reason it's taken so long for us as a profession to start to implement this was the safety concerns. So I think if we can get more research on how safe this is, it'll start being used more widespread, and then, you know, people can get better faster, stronger faster, reaching their goals faster. One of the safety concerns, I mean, I'm sure you can predict potentially, is autonomic dysreflexia with our people with spinal cord injury or deep vein thrombosis. Essentially, this next study looked at that and found that they had no increase of those phenomenons in after doing blood flow restriction. So in that specific study, there was no increase, and I can't find any really that have shown that there's an increase in autonomic dysreflexia or DVT. Of course, we have to be diligent in our diagnosis. We're not going to be doing this with people that have clotting factor disorders or history of DVT on that limb. Like you're setting yourself up for failure. But I think if we look through our potential patients, we just have to do a good job of assessment and analysis there.
So just to be clear, like on the autonomic dysreflexia,
Mm-hmm.
are you using this with someone who has a history of it? Or are you saying if they actively have autonomic dysreflexia, that you might consider that a contraindication for the time being?
Um, so if they were experiencing autonomic dysreflexia, we would not use it. If they have a history of autonomic dysreflexia, we could use it. And I'll get to that in one of these uh, studies. But essentially, most people that have a cervical level injury that's incomplete or complete, more likely complete, will experience autonomic dysreflexia in their rehab, um, just because they can't feel below their level of injury. So a stimulus that's going to be, noxious in any way, that's our body's way of telling us, hey,
Mhm.
something's going on. So you would think using blood flow restriction, that's a possibility that that might happen. And what they have found is they have no increased experience in AD using BFR.
Okay.
And then the next one down is just a survey they conducted with medical professionals and therapists that are using BFR, and they were just wondering what kind of reports are you getting from your patients? Like what are the patients thinking? What are the worst things that are happening during blood flow restriction? And what they found was the worst things that were happening was fatigue, soreness, intolerance to pressure. And it's like, well, you get that with traditional strength training anyway, so why wouldn't you use this device that
Mhm.
works? And they also found that people who have a history of working out and know what like a good sore feels like, they actually appreciate um, the blood flow restriction feel afterwards because of, oh, I felt like I got something out of that.
Mhm. So there might be like an educational component, like, oh, that's actually normal
Totally.
versus, oh, there's something wrong.
And it's just like any of our clinical decision making. I mean, if I'm talking to somebody, one of my patients that's really hesitant to do something like this is going to be a process. It's not something I'm going to push on them. I mean, it, there's an educational process of, hey, this is something we can do. This is a tool we can use, but we don't have to. And if you don't want to, that's fine. Because
Mhm.
research does show if someone believes that it's not going to help them, it probably won't. So
Mhm.
why do it? And then finally, they actually did a case report on someone with quadriplegia with known autonomic dysreflexia during traditional strength training to see if they applied the blood pressure cuff to him during workout that he would experience autonomic dysreflexia, and he did not. So he actually experienced AD when he's working out traditionally, and then when they brought in the blood flow restriction, he did not experience. And that's just a case report. So I thought that was really interesting. They like really wanted to dabble with it, like, oh, we got someone who's already known to have this. Let's try to see if we can do it again. And like, he did not experience it. So to me, that means, hey, this might be a safer way to do it than trying to get him to a point where he's pushing himself so hard that he's up in that 60, 70, 80% of his one rep max. Why don't we keep him down to that 20 and 30, add this cuff, and he gets the same, if not better results with less
Mhm.
intensity.
Less load.
Yeah, less load, exactly.
A couple of questions on some studies. Did you see anything related to peripheral plaque buildup in the arteries and any impact on that?
Yep, that's one of the contraindications.
Contraindications. Okay.
Yeah.
So Eleanor, we'll touch on that a little bit more on contraindications. Did you see anything in the research on CRPS and
Yeah.
utilization with that?
Yep. So yeah, that's another one where it's use your clinical judgment.
Okay.
Um, that's a very complex condition to treat, and so you want to make sure that maybe starting if I could see me developing a good rapport with that person obviously first, showing them that what we're doing is working, not necessarily blood flow restriction, but then building some chips in that way to then they trust me more, and then maybe we start at a lower percentage of occlusion, so instead of like 50% of the arm, start with 20 just so they get used to the device, get used to the protocol, and go from there once they build their tolerance up, just taking it slow.
Got it. Thanks.
Okay, here we go. So here's a long list, and this came from the course we took from Smart Tools. Um, Essentially, on the left column, you'll look at some of the diagnostic findings. We want to be diligent and making sure that our patients aren't coming to us with obvious poor circulations in their system. We want to inspect the skin, nails, limbs for hair loss, anything that demonstrates like vascular deficiency. I'm going to be careful with diabetes, cardiopulmonary conditions, hypertension, infection, all these things where you don't necessarily want an immune response to flow into your limb. We would probably caution away with BFR. The people that I've been using with have been otherwise healthy, besides usually spinal cord injury is what we're really looking at right now. We have used this with people that have MS, Guillain-Barré, um, non-traumatic spinal cord injury, stroke. So obviously with stroke, depending on the type of stroke, there's going to be some cardiovascular things there. We just have to be smart about, are they, you know, are they in a good spot health wise to utilize this? Some of the contraindications that I find to be pretty obvious, like any clotting issue, we don't want to close a vessel on someone who has an already uh, issue with clotting, pregnancy, an open fracture, open wound. I think it would be okay to do um, blood flow restriction if someone had a wound, say that's healing on their sacrum, but you're working on their elbow extension. There's not going to be any effect distally. I don't think so. It would be okay to work on that one limb that's very far away from that wound, but we wouldn't want to do blood flow restriction on someone who has a wound on their elbow and we're trying to promote elbow extension.
Mhm.
Um, since this does have a little bit of a neural drive component and a sympathetic response, if someone with a TBI and we've got some intracranial pressure issues going on, we wouldn't use BFR because we're going to increase by using BFR, you're increasing that heart rate, increasing the neural drive. So for someone who's already heightened in terms of their pressures or even environment, we don't want to increase that. And venous deep vein thrombosis, like I said earlier, um, anyone who's had like a vascular graft in that limb that we're uh, treating, and there's some other ones that you guys can read, but essentially what we've been doing is using it on people that are healthy and might have had a traumatic spinal cord injury but no other issues prior to that. And that's where I think there needs to be more research. Like some of these things are obvious, but there's others that who knows, maybe that will help, but we're not experimenting on that right now.
Here's a couple other questions. Sorry if you're going to answer these, so feel free to
Oh, you're
push
good.
them to later. There's a question about utilization with contractures, and do you suspect this would be helpful in that regard?
I do. I really do. I think uh any way to get more of our body to pay attention to that extremity from a healing aspect has potential. Contractures are a huge issue, obviously. Like they have to be in a prolonged stretch for 6+ hours. Like, is that is that something achievable in traditional inpatient rehab? Yes, with like serial casting and things like that. Um, but the answer is really I don't know. But what I've seen so far is this has been helping with other conditions that I didn't think it would help with. So I don't think it would hurt for someone who is very well versed in contractures to start looking at that. Looking at that.
Along those lines, this wasn't part of the question, but what have you seen in terms of tone management and like spasticity, things like that? Are you noticing anything or having other considerations about that?
Yeah, I have one individual that I can think of that reminds me of when the muscle does fatigue, the spasticity is lessened. So essentially, we're fatiguing the muscle more so than he probably ever has up to that point, and so you're seeing at least a day, not probably more than that, of reduced spasticity.
Hmm.
But the same thing goes for, say, dry needling. If you're trying to manage spasticity, there's so many. The best way to do it is stretch. Then there's medication management, and then there's other things that like Botox and stuff like that. But more and more less invasive techniques are coming around, like dry needling. They just had a skip last a couple months ago. A case study came out proving that dry needling does in fact reduce spasticity in the short term.
Hmm.
I'm thinking, well, we can talk dry needling a different time,
Hmm.
but uh, I I don't know. I think there's promising ways to do things differently than what we've been doing the past 20 years.
Hmm. Great. Maybe we can add dry needling to the list next year.
Okay. All right. Any other questions on that we want to talk about
Uh,
now?
just a quick, Eleanor, the spasticity, he just mentioned that spasticity was pretty short-lived in terms of decrease. So call it hours to maybe a day is what he's seen in practice, but more to come on that one. All right,
Yeah.
let's keep moving.
Okay.
Oh, actually, one more.
Yeah.
Any thoughts on utilization in the ICU and acute care, specifically for those with a post like spinal fracture? I'm guessing it's like a vertebral repair. Any issues using this like distally from that?
Yeah, I don't think we know, and I think that's part of the gaps in the research right now, and I think it could be very, very beneficial for people earlier on in their rehab. Um, we just, I think, need to make sure it's safe to do, let's say, we already know it's safe to do a year out. We're starting to do it, the 3 month mark out. I think the more research, case studies, systematic reviews we get out there with the midterm post op or post acute setting, the more we'll feel safe doing it earlier and earlier on in the stages.
Hmm. One other question on contraindications. Anything in the research on specific cancers? So the question is it contraindicated for all cancers or just certain types? Was there anything in there that you saw?
I didn't. I think it's one of those things where in our course we learned if someone has cancer, don't do it. But I'm guessing, some of the cancers that are, I don't know what the term for it, but like let's say prostate cancer that someone's had for 6 years, it's not like active.
Hmm.
I think that would probably be okay. But if we have an active uh start, you know, skin cancer on that limb, like let's not bring more blood flow to that region.
Yeah, great. All right, great questions. Keep them coming. We'll keep moving.
Yep. Okay, so now that we got through all that, let's like see what we're actually doing in the clinic. This is an example of how we're using BFR in our fitness center. Essentially, it's pretty bare bones what you need. Essentially, you just need a blood pressure cuff. I recommend. I mean, I like using the smart cuffs. I have a peer who really is a fan of the Owens recovery science. But to me, these have been working great and they're very versatile. And then a way to progress the resistance. So you can see here in this picture, she's using a green band. Initially, when we first started doing this, she was using no resistance. So we upgraded to a green band. And I think after this, we might go overhead tricep extension instead of laterally. There's just different ways to progress it. There's not much research for a protocol in the neuro population. So I kind of just adapted from what we saw in the orthopedic and athletic scene. Um, and so what we've been doing is we've been doing BFR 2 times a week. If we're doing it on the upper extremity, we're utilizing 40 to 50% of the limb occlusion pressure. So that's 50% of uh, the pressure that would be required to fully occlude blood flow. So they're still getting blood flow in. It's just harder for blood flow to get out, which is why you're getting that metabolic change, those metabolites coming in and staying. And then when we take the blood pressure cuff off, blood is rushing back in, bringing all those good healing cells.
So practically, you're taking their blood pressure. Let's just say it's like 120 systolic.
Mm-hmm.
You're just cutting that in half, and that's what you're using as your number.
Yep.
Okay.
And that's what I'm using for protocol. But I think we change that based on, let's say, tolerance. So say we had a 120 over 70 and we occlude them 60 mmHgs. Like, man, that feels tight today. It's like, all right, well, I want it to be hard at that 12 rep range if we're doing 20. If you can't get 6 because it's so hard, well, let's reduce the occlusion pressure to 40. And that way you can achieve that 12, and then 13's hard, 14's harder. Eventually you're getting a response where you can barely finish the 20
Mhm.
as if you were maxing out.
That's a really good point. So you're having to analyze it day to day, and one day might be different than another, just like you would see in an able-bodied person. Good days, bad days, things like that. Question on like, are you treating the upper extremity and the lower extremity in the same day? Let's just say you're doing upper extremity Monday and Wednesday. Would you do lower extremity Thursday, Friday, or would you treat that in the same day? Or are you still playing around with things like that?
I think you can. I definitely think you can. And we've been doing it only 2 times a week, whether or not we do upper or lower, but we've done upper and lower on the same day. That's safe to do. Um, our fitness coach Tyler's also trained to do this, so when I'm not in there, he might be doing leg press with somebody with a BFR cuff. But we've been trying to keep it to 2 times a week because think about it, if your muscle's sore, especially in that one specific limb, if your muscle's sore, delayed onset muscle soreness lasts 2 days, you're not going to want to just do this every day because
Mhm.
then you'll be breaking down the muscle without giving it time to heal.
Mhm.
And so then my goal is that we get 4 sets of 20 reps with a 30-second rest in between. What I've been seeing is people are able to, well, and I'm having to assess, you know. So the first time we do this, I'll just let's go without resistance, and they'll get 2 sets, no problem. But by the time they get to the third set, they're having trouble at rep 15. And by the time they get to the fourth set, they're having trouble at 12. And that's the goal. I want to find a spot where they're having trouble finishing the movement because that's how I know they're near their maximum output. So the goal is 4 sets of 20 reps with 30-second rest. And I'm also asking them an RPE, like a rated perceived exertion after that. So how hard was that on a scale of 1 to 10? And generally it's an 8. And that's what we're going for. 80% of 100 of our max. So,
Any thoughts on passive rep movement?
yes. So some of our people can't yet achieve full range of motion. Let's say let's use bicep for example. Let's do a bicep curl. Say they can bend their elbow 50% of the way, but can't achieve full flexion in that limb. So what we would do is put the blood pressure cuff on, have them do what they can, and then active assist the rest. And I predict that that's actually going to help them achieve that range of motion that they're lacking. Based on what we've seen, that's been what's going on.
So it's basically like having a spotter,
Yeah.
right? And so you're pushing that muscle to the point of fatigue, and you could, and in this case you can't lessen the weight of the limb, right? So
Right.
like if you're doing a bench press and you have a spotter, and at 135 pounds you need a spot, but you could drop it down to 125 and be good. We don't have that luxury
Right.
in the case where they can't lift the weight of their limb.
Right.
So
And
that would
that's
be
where
the application.
exactly.
Okay.
Perfect.
Here's a question on limb loss. Any contraindications for working on the residual limb?
I do not know. So are you talking like say someone has a,
You lost a hand, but you still wanted to work the elbow and the
Like,
shoulder.
yeah, like
yeah,
below
I would think,
elbow or
I mean, there's going to be some vascular reconstruction in there, so I would proceed cautiously with that. But I think that's, like I said, for a lot of this, just lack of research.
well, and I would think that once incision is healed, once you're kind of maybe even further down
Right,
and you're looking at regular strengthening anyways,
right,
like that seems like that would be
right.
okay once you're good.
Yeah, you think about, like, this isn't as extreme, but you think of like ACL reconstruction. They've been doing this for decades on that, and that's a lot of reconstruction of the limb as well. But yeah, I agree. I think it would be safe, but like I would approach that cautiously, but I don't see any reason why, say they had a below knee amputation, we could do quad sets, which is essentially just laying on your back, pushing your knee down, making your quadricep activate, and just putting a blood pressure cuff around that to make that activity feel harder for them is going to help them build strength in that limb.
Balance
I think that'd
strength
be a
injury.
great idea.
Well, and plus, I think based on what you said earlier, there's going to be less wear and tear on the joints and all of that, which actually might be good, especially earlier on, I
Yeah.
would think.
And the reason they found this out is they were actually trying to reduce atrophy in the limb post-op in athletes. So you think about all these athletes that are trying to return to sport faster. So a typical ACL repair back in the day, it's taken 9 months to safely get them back. But they're using blood flow restriction early on post-op to reduce the muscle wasting because they haven't been using their limb. So they can hit the ground running when it's safe to run per se.
Yeah.
So same
Which
idea.
same application there, right? Where limit the atrophy of that limb, then you get probably a quicker fit on the socket and all
Yep.
the things that we know that need to happen. So yeah, similar application.
Great. Okay. So why is this important? Um, I just think about all of the tools we use to help people get back to life, and I think that's why we do what we do. So this is just another one of those. It's just another tool to help people get stronger so that they can do things like this. So let's talk through this case example. So our goal for someone who has an incomplete spinal cord injury in the cervical level is to improve their transfers. A lot of times that's what we're working on. We're working on improving the functional mobility, which will include transfers, bed mobility, activity tolerance, things like that. The way to do that is to address the impairment, which is going to be to improve the tricep strength. So how do we do that, and how do we do that faster? Because we got to get this guy back into his environment ASAP. We're going to add BFR twice a week with traditional strength training. So we're still going to do the things we do in the fitness center outside of physical therapy sessions, but we're going to focus on the triceps for this guy just for the specificity of his transfer. We're going to stick with that 4 sets, 20 reps, 50% limb occlusion pressure. So what we're finding is people are progressing from the level of assist they need for a specific transfer in 6 to 8 weeks, which is really fast in the rehab world. I mean, to go from a moderate assist slide board transfer to an independent popover in 8 weeks is fast, is very fast. And we're seeing that happen. His report, feeling like he was getting a workout, reporting muscle soreness in the next day, which this guy has experience working out, so he knows what that feeling's like, and it drives him to push harder in the gym when he's here versus without the BFR. Oh, pulling on the band 50 times, really? That's not giving me what I need to feel like I'm doing something workout wise. And then ultimately the goal that we always have is to get to that participation level. So how do we improve the functional deficit, which was his transfer, to ultimately get him hit back into the biski to participate in activities that make him happy and feel like he can live a fulfilled life going forward with injury. Uh, so yeah, that's the why behind the what.
Mm-hmm.
Doing okay on time?
Really great on time.
Okay. All right, looking forward. Now that you have an idea of what blood flow restriction therapy is, I just want to identify some of the things that I feel like we need to do looking forward. Research gaps. I think we need more case reports from the experts to drive larger scale studies. Like I said earlier, it's like we know this stuff works. It's just a matter of getting it out there and getting more people doing it and proving that it's working so that more systematic reviews can be performed. And that way we can get more comfortable utilizing this earlier on in the rehab process. Spreading the word. So we've been doing this for, a year and a half, 2 years, and finally I'm feeling confident enough that like this is working. We need to get this out there. And so just spreading the word, just like what we're doing today, making people know about it, you know, might help some of our other referral sources to start doing this before we get our patients. So I know it's been talked about in the spinal cord injury world at some of these conferences, but it's not known to be something that we do post injury yet. Dosing. I've talked about the 4 by 20. That's just what I've been using. Is it optimal? I don't know yet, but it's been working. So I think more research needs to be done on what the dosing looks like. And I think we could even branch out into the endurance spectrum and put this on somebody while they're using the FES bike, for example. So they have no activation of their limb, but you're using an external stimulator to activate the muscle with blood flow restriction. Like what happens then? Maybe obviously it's going to be a lower limb occlusion pressure, but the muscle's going to have to work harder, even though it's not their nerves activating the muscle. Just some ideas I've been thinking about. And then finally, home base use. Like, how can we get this dialed in to a point that when they leave us at QLI, they can continue um, progressing their muscle strength? Like, I've only seen this with my people for 2 to 3 months at a time, and then they go home. Are they losing that strength that we gained? You know, or are they able to carry forward what we've been working on to continue to progress their strength?
So one question, this is kind of like on the home-based use, but do you know like what does a cuff cost? Like how accessible is it cost-wise?
They vary in cost. Um, Obviously, you get what you pay for. We bought 4 smart cups for $800.
So
Two
about
different.
$200 a pop.
Yeah.
The reason I'm thinking about it is so we on our tele-rehab program, we have lots of people who I'm sitting there being like, these exercises are fine, but they're below the threshold of what I would want in order to make progress, mostly because I'm limited by the resources of what they have in their home, especially if they don't have access to a gym or even could be functionally like they just can't tolerate something heavier. So it gets me thinking like, wow, if these were a bit more accessible, we could provide that. And then I could, as a clinician doing virtual rehab, start to apply it in a way that we get better results.
I think so. I think that you're spot on. Um, we get when they're ready to be transitioned home, you know, you'll come down, work with them a few times, make sure that they feel comfortable applying the cuff themselves or having someone help them get the cuff on, watch them, make sure they're competent in using the device, and then you have a $200 deal that's going to really have a lot of bang for the buck, and you can monitor them from afar.
Well, and at the end of the day, if it cuts down on visits that we're using in the outpatient setting, that $200 is money well spent too. So, I mean, I think as I'm thinking about it, I'm like, oh, this might be really smart.
Yeah. Cool. All right.
All right, so let's go ahead and launch the poll question. We do have a couple quick hit Q&A that are still sitting out there. So I'm gonna go ahead and launch this quick. It's a really hard one today. All right, please answer the poll question. This is to get your CEUs. In terms of Q&A, some of these, in terms of contraindications for CRPS and RSD, Connor had mentioned previously, no known contraindications, but this would be one that you use your clinical judgment, maybe ease into it in terms of the occlusion. So This falls into the category of just more to come, need more research, but encourage you to try it with caution. Similar post-stroke, yes, we are using this post-stroke at our setting. The question I think is more specifically at the acute rehab setting. I think I know the answer to this based on what you've said, but maybe just kind of close the loop on that one in terms of your thoughts on acute rehab versus we're using it a step further in the continuum.
Yeah, I think you just have to use your clinical judgment, and we need more research. Um, Obviously, with stroke, it's very complicated in terms of what type of stroke, hemorrhagic versus like a clotting deal. Um, I think I think we need more research there, but I think it has a high chance of being very good
Yep.
modality.
In terms of the anticoagulants, I think we got that one, but that would be one that would be probably a contraindication, is my guess.
Yep.
All right, I'm guessing you don't know this one, but there's a question on coding for billing. Did they talk about, I guess I shouldn't have said that first part. Maybe you do on what training you did. Did they talk about
Um,
like CBT codes and
yeah, I don't think like for coding in like an outpatient setting, uh, I would think that they would just be using their typical Therex or NeuroRead and then using this as a supplement. Like it's Yeah, I don't think there's a code for BFR just because it's not something that only therapists can do. Athletic trainers can do this, gym coaches can do this, general public can do this, get a certification.
so you're not really billing this as like a modality necessarily, such as like eStim or ultrasound. This
Right,
is just an adjunct to whatever Therex, like you said, you're using. Probably isn't going to be like a billing issue.
right.
Um, oh, what was the rest of that? Oh, this is a side question. Is there a certification? What do I have to do if I want to do it and I'm a clinician or a trainer or whatever?
Yeah, there's multiple courses out there. I I think the Smart Tools course was really good. A lot of us got trained up on that. I have some colleagues that work elsewhere that used Owen's recovery science. And he says he's gone through both of that and the Smart Tools, and he said they're comparable. Owen's recovery was a little bit more expensive, so I have a whole laundry list of um, courses and different types of devices that I could get out to you, Steve, or to whoever. We can send those out.
Yeah, if you have specifics on training, or by the way, you're not being paid by any of these
Oh no,
uh, organizations. It's just what we've used. So just for you all listening, wasn't intended to be a marketing deal on that, but let us know if you need more information on that. Happy to share that. I can get that from Connor. Um, looks like there's another question on DVT and PAD contraindications. Yes, this would be a contraindication. Contraindications will be listed in the slides as we send, just for a refresher. Other than that, I think we got everything. And we'll get folks out of here a little early. Connor, this was really great information. I know I learned a ton today. I'm sure our listeners did too. So we really appreciate you sharing everything you've learned. And I love the idea of spreading the word. That's why we do this webinar every month. But this is a perfect example of something that's new and fresh. We'd love to be able to bring it to our listeners. And then if you all have feedback for us in terms of what you're finding, what you've seen, we want to learn that too. So feel free to share that back. We always really value your feedback. So remember, as you sign off, you're going to get the feedback form, hopefully automatically populating. If you don't get that, let Don or I know. We'll get you taken care of. And then with that, we are off next month for the month of December. No webinar, and then we'll be back at it after the first of the year. So happy holidays to everyone. Thanks again for joining us, and we appreciate all your partnerships and glad to be here. Thanks again, Connor.
thank you.
Thanks, Connor.